Good afternoon, everyone, and welcome to Fountain House's 14th Annual Symposium Luncheon. How many of you have attended every luncheon since the beginning? There are a fair amount of us, veterans of these luncheons, for a good reason. We would not miss this event, this annual event, for anything in the world, because it supports Fountain House, and it also enables all of us to learn about different types of mental illness from the foremost experts in the field, and this specific field that we address every year. And as those of you who have been here before know, that we take a specific topic every year, and today's topic is borderline personality disorder. And I will introduce the panelists in a moment, but they are the leading experts, and a couple of them are pioneers in this field, and we'll tell you about that in a moment. But I mentioned that this is about Fountain House as well. So here to tell us about Fountain House, its mission, and the team of volunteers responsible for this event every year is one of the most dedicated among them, longtime co-chair Kitty DeChazal. Kitty, please come.
Welcome, and thank you for all coming to the Fountain House Symposium, which has become a major forum in New York for the discussion of mental health. It is also Fountain House's most important fundraiser, and we're thrilled that so many of you came today. We could not have accomplished this without the efforts of my dedicated co-chairs, Pat Begley, Alex Herzen, Carolyn McKenzie, Anne May, Florence Perlong, and Elise Wilpond, and the founding chairs, Lorna Grave and Lynn Nicholas. I also want to give a special thanks to Ralph Aguila for being a medical advisor to the team that created the symposium. Since 1948, the Fountain House model has been a very successful, cost-effective, evidence-based program that empowers people living with mental illness. It has been at the forefront in education, employment, and wellness. You can read more about our latest initiatives in the lunch program. I will now turn the microphone over to Consuelo Mack, who we are so pleased to have as our Master of Ceremonies again this year. Consuelo is the executive producer and anchor of Consuelo Mack Wealth Track, an expert in business television and a dear and loyal friend of Fountain House.
Thank you, Kitty. And thank you all of the co-chairs of this event as well. And I just want to mention that an event like this takes a lot of work, and the co-chairs have been tireless. They're dedicated to this cause and to Fountain House, so I appreciate them so much. So I want to give them another round of applause as well. So thank you for doing this. So mental illness affects 1 in 4 Americans. This year's focus, as I mentioned earlier, and as obviously you can see it on your program, is borderline personality disorder. When I heard about this topic, I said, what on earth does that mean? And when you talk about somebody who is borderline, even I know as a layperson that it has very negative connotations. I always thought it was like, borderline psychotic. And it has actually been called, and the panelists will speak to this, the leprosy of mental illness. It really has a stigma attached to it. A very good friend of mine, who happens to be Lynn Nicholas, who was a therapist, told me when I asked her about this disorder, and it wasn't recognized a disorder until 1980, so the research on it is young in the field of mental illness. And the reason that it is now known as a specific disorder is because of Dr. John Gunderson, who I'll introduce in just a moment. But Lynn told me that when she was in training as a therapist, and when she was one, professionally that no one really understood the diagnosis. And so we've come a long way since Dr. Gunderson identified it, and we're going to hear that it is no longer, it's a devastating end. It's actually a hopeful beginning, because therapy and the treatments that we're going to learn about have to help people who have that diagnosis a tremendous amount. And so Lynn said she was looking forward to learning a lot about borderline personality disorder, and she's not going to be disappointed. So we have 3 panelists here who are leading experts in the field, and we're asking them to do the nigh impossible, which is to encapsulate a lifetime of work in 3 brief presentations and then be questioned by me, a layperson, to make sure that we come away with a basic understanding of the disease, its treatment, and its damage and recovery on a very personal level. But I've been talking to them, and I know that they are completely up to the challenge. So I look forward to hearing from them. But first of all, we always poll the room and want to know how many of you have had a personal experience with, yourself, your family, with friends and acquaintance with what we're going to call BPD from now on. So could you raise your hands, those of you who have had some experience? So actually, and you'll learn that it's more prevalent than many people realize. Now, I asked you a second question, and that is, how many of you have very little knowledge about BPD? And count me in that number. This is going to be an exciting event for you, because we're going to learn a lot more about it, those of you who have experience with it and those of you who don't. And it is much more prevalent than we realize, and we'll find that out. So here to enlighten us are our panelists. First of all, I guess it's stage left, my far right, Dr. John Gunderson is a pioneer in borderline personality disorder diagnosis, research, and treatment. He is professor of psychiatry at Harvard Medical School and director of the Personality and Psychosocial Research Program at McLean Hospital in Belmont, Massachusetts, which actually is an area where I grew up. And McLean is famous, for any of you who know a great deal about mental illness. His seminal research on the diagnosis, families, treatment, and every other aspect of BPD helped transform the diagnosis from a psychoanalytical construct — you can tell I'm talking the technical language here — into an empirically validated and internationally recognized disorder, and earned him the recognition as the father of the disease. He is also a prolific author, and among his books are the Handbook of Good Psychiatric Management for Borderline Personality Disorder. Plus, he's also co-authored several books with one of our panelists, Dr. Perry Hoffman, who's next to him, including Beyond Borderline, True Stories of Recovery from Borderline Personality Disorder, and we will hear some true stories today as well, and Understanding and Treating Borderline Personality Disorder, a Guide for Professionals and Families. Which leads me to the next introduction of Dr. Perry Hoffman, a PhD, who is a pioneer in the concept of the importance of family in treating BPD. She is president and co-founder of the National Education Alliance for BPD and co-designer of the Family Connections Program. The Family Connections Program is so key and will be in this conversation. It's a free of charge 12-week psychoeducation course for families affected by BPD, and it is now available internationally, I think in 17 countries. She's also past director of the dialectic behavior therapy programs at 2 prominent New York area hospitals, and she was a past director. And you're going to hear more about the importance of this therapy later, and that is BT. I am slightly dyslexic, so I'm going to have a problem with these acronyms. But at any rate, they're key to the understanding of this disease and its treatment. So I just mentioned how important family is considered to be in treating BPD, where the last thing the patient wants with this particular disorder is a family member involved. because a characteristic of the disease is antisocial behavior and impulsiveness and self-destructive tendencies, all of which you'll hear much more about from the professionals. But our final panelist that I'm introducing is a Professor Marie Paul de Valdivia. She gave up her career in business when her daughter was diagnosed and has devoted herself personally and professionally to the disease ever since. And needless to say, her daughter has given her permission to speak about her experience with her. In the last decade, she has become an assistant clinical professor of social work and psychiatry at the Yale School of Medicine. This is in the last decade, having had several decades in business. Talk about just a calling and dedication. And she is, clinical professor of social work and psychiatry at the Yale School of Medicine, a dialectical behavior therapy program leader at Yale New Haven Psychiatric Hospital, and the executive vice president and family connections leader. They're all interrelated of the National Education Alliance for BPD, where she works with Dr. Hoffman. Plus, she is founder of Families Online, which coaches families on dialectic behavior therapy-based family skills. So each of the esteemed panelists will present on many different aspects of BPD, with Dr. Gunderson laying the groundwork for us. So please welcome Dr. John Gunderson to the podium.
It's an honor to be here and to present to these Fountain House associates and supporters. It's also an honor for us to speak on behalf of a group of patients who are usually underrepresented in both public awareness and in support from our foundations and government. Borderline personality disorder was, when I first became familiar with such patients, considered intractable and untreatable. Time magazine had an article about 15 years ago saying the disorder doctors least like to treat. This is a disorder that occurs in about 2% of the population, which, put that in perspective, is roughly 10 times or more the percentage of people with disorder like schizophrenia. They constitute 6% of all, not psychiatric, but all emergency room visits. They often come back and back and back in crises. They constitute 20% of all psychiatric admissions. This is an enormous sector of the mental health burden felt by professionals and which the public knows little about. What the hell is it? You asked that question. It's not easy to answer that question because borderline personality disorder has 4 different types of psychopathology or disorder combined. These are people who are impulsive. They have behavioral problems, most notably by self-destructive behaviors. These are people who are highly emotional. Most notably, they are frequently and inappropriately angry. These are people who have a disturbed and unstable sense of self. And maybe most specifically, these are people who have a pattern of interpersonal relationships which are marked by shifting radically from somebody being idealized to being devalued. So in thinking about where this came from, it was as if there's 4 types of disorder broadly based in the larger community, which maybe just coincide. Genetic studies established a very different understanding. First of all, about 55% of the variance, that is, whether somebody has this disorder or doesn't have this, is stockpiled in the genes they're born with. And a single common underlying factor lends this syndrome, made up of such disparate parts, a coherence. It has an internal integrity to it. A simple way for you all to think about this is that our 3 criteria, which can identify about 85% of people with disorder. If you have people with severe abandonment fears who are openly and repeatedly self-destructive and who have undue and inappropriate levels of anger. If you have those three criteria, the chances are you have borderline personality disorder and it won't fit any other disorder. Nonetheless, that term borderline raises a question, borderline to what? And why was it named borderline personality disorder? It has to do with what I've already said, is the instability and the breadth of the disorder. The behavioral problem suggested it may be an atypical form of antisocial personality or conduct disorder. The emotional problems suggested it may be an atypical form of major depression, which commonly co-occurs, or bipolar disorder. The interpersonal problem suggested this may be a variation on narcissistic or histrionic or dependent personality. And the disturbed sense of self, that may be just a variation on normal adolescence. One of the problems with this is, though the validity and the separateness, the distinctiveness of this disorder is at this time established from these other disorders, these people are still frequently misdiagnosed. About 40% of psychiatrists actively don't give the diagnosis even when they know it exists. That is in part because many of them have not been trained to treat it, and because the same kind of stigma which I talked about at the beginning of this talk of being intractable and untreatable is still widely accepted even within mental health professionals. The diagnosis most frequently given is major depression and bipolar disorder. Psychiatrists are more familiar and comfortable giving those diagnoses because then there are medications which can be prescribed. The prescription of antidepressants and mood stabilizers, however, does modest amounts of good for these patients, and what it does over time, after repeated failures, is consolidates an unnecessary sense of despair in the patients and their families, sort of confirming the stereotype of them being untreatable. Under circumstances which you'll hear about from Dr. Hoffman, where very valid and empirically validated treatments do exist for this. These are people who, as children, were hypersensitive and emotional. They made it difficult for their parents to be at their best. The parents themselves often had troubles, which got exacerbated by a difficult child. So you sort out something that is neither genetic nor family, but some interaction which frequently is in the background. The children themselves grow up feeling that they did not get what they needed, and they enter their adolescence hungry to form some form of exclusive relationship with somebody who will be dedicated to them and only them. Such a prototype of a relationship is predetermined to fail. They need too much reassurance, they get too jealous, the relationships fail, and that confirms for them that there's something either wrong profoundly with them or that they've been exposed to a cruel world. In the one instance, there's something wrong and they're bad, and the other way, the world is bad. That's called splitting. When these relationships fail, they often they are threatened to fail. They cut themselves. They also become extremely angry. If at that point they start feeling held, somebody leans in and takes care of them, they go back to being a depressed waif that you want to take care of. And if somebody steps away in the face of their anger or their self-destructiveness, they have an intolerable sense of being alone. And that's when serious dissociation occurs, paranoid ideas, and desperate suicidal acts. About 10% will actually kill themselves. The prognosis for this disorder is remarkably much better than any of us who were around from the founding of the disorder ever imagined. About 10%, about 15% remit within the first year, about 25% to 40% by 2 years, 60% by 5 to 6 years, and 85% by 8. So that's a gradual level of recovery. But when they recover, they stay recovered. And the speed at which they recover is accelerated by the treatments now available to them. And I'll let Perry Hoffman tell you about that. Thank you.
Thank you, Fountain House, for highlighting borderline personality disorder. It's such a pleasure to be here. We saw the facility this morning, and I'm still spinning for all that's out there and all that you are doing in these kinds of luncheons, sponsoring continuing work. It's current information that will help address the stigma and frank discrimination of this disorder. This disorder is highly discriminated against, and I think that's an important fact for people to know. Not a week goes by where I don't get 3, 4, 5 calls, either from someone who's just been diagnosed with the disorder or a family member who says that their relative has just been diagnosed. And if you go on the internet, you'll know why these callers are so desperate, because most of the websites talk about all the negative things that were previously thought about the disorder. It's not treatable. These patients, the best thing to do if you're in a relationship is to get out of that relationship. If you're a therapist, only treat one patient because they'll suck the life out of you, and this goes on and on the internet. And so what I say to the caller, I say, I hope it's borderline personality disorder. And the reason is because people do get out of the mental health system with this disorder. It's a highly treatable disorder. I call it the good hope of psychiatric illnesses. Schizophrenia, bipolar disorder, depression, those are lifelong. Thank goodness there are medications to address them. But those are really lifelong illnesses where people get better and then have another episode. As John said, with borderline personality disorder, once people remit, they stay remitted, and that's such a good news. So my take-home message to all of you is that this is the good prognosis diagnosis, and it's the voice of hope. So as John explained that early on what was thought of with this disorder, how do we account for such a sea change now that many of us are seeing this disorder in a different light and feeling more hopeful? Well, first is the longitudinal studies, and Dr. Gunderson mentioned the outcomes of those studies. There were 2 studies basically done. One is the CLIP study that was in New York at Columbia with 14 sites. And the other is an ongoing study still now at McLean Hospital, and that's been going on, I think, for about 24 years. And so the statistics that you heard from Dr. Gunderson, that's what's begun to give hope that people do get better and actually stay better. And then, of course, the next thing that's been so crucial has been the evidence-based treatments. And evidence-based means that there's research behind this that's proved that the treatment works. So the treatment that's most prevalent and really the first to come out of the woodwork, so to speak, is dialectical behavior therapy. And this was developed by Dr. Marcia Linehan, who's at the University of Washington. And Marcia, as she likes to be called, has had the lived experience with borderline personality disorder. And when she was in her own hell, she vowed to get out of her hell and help others get out of their hell. And she's actually done that. I mean, she's an icon with this disorder, along with John Gunderson. So there are now 25 studies on DBT that have proven that it works, and it's a worldwide phenomenon that people want DBT. So what is DBT? So the word dialectic means finding a balance between what seems like 2 opposing themes or ideas, and the basic dialectic in DBT is radical acceptance and change. So what do we need to radically accept, and then what can we do in the context of acceptance can we do to change? So that's the formulation of DBT. It's a cognitive behavioral approach, and it's very skill building. There's a manual that therapists follow. These skills are even more widely used now in other diagnoses, and actually several years ago I presented at the New York City Women's Bar Association because they wanted to know about these skills. The skills are being taught in schools now. What Marcia Linehan has done is really incredible, and there are other treatments that are also equally good. So the next one is mentalization. This treatment came out of London with Peter Fonagy and Anthony Bateman, and this treatment is, as I said, is called mentalization, and it's about mentalizing. It's about the therapist and the patient in the room together, trying to mentalize and understand what the other person is thinking. And that skill then is applied, hopefully, to relationships out in the patient's life. That also has research that came out probably in the mid-1990s, and it continues to grow. It's not as prevalently available as DBT, but as time goes on, I'm sure it will be more widely available. The third is called transference-focused therapy. This was designed by Dr. Otto Kernberg and colleagues. This treatment probably even dates DBT in terms of seeds that Dr. Kernberg planted. And then in the mid-90s, he and colleagues manualized this program so that it could be replicated and researched, et cetera. That's actually very prevalent in New York. There's a whole personality disorder institute where people can get transference-focused therapy. And the last, but by far the least, and the one to keep the spotlight on, is called General Psychiatric Management. This is a course that Dr. Gunderson designed with his colleagues. And what's so wonderful about this program is that unlike the other treatments that I've described, this one is very easy to learn. You can go to a training in a day or two and then implement it. It's very practical. It also has coping skills similar to DBT. And it also focuses also on social rehabilitation, jobs, and things that actually we need to be helping our patients do more. It's one thing to have a symptom reduction and not meet criteria for the disorder, but how do we get these folks into a real life, into a relationship? Borderline personality disorder occurs in the context of relationships. So if someone were to live on an island, they wouldn't look like they have borderline because the symptoms don't bounce off in a relationship. So this latest treatment is something to really be watching. Because it's easier to get trained, it will be more widely available as the years go by. So the other thing I want to also highlight here is the importance of early identification. So borderline personality disorder seeds can actually be seen in childhood and certainly in adolescence. And there's a myth that you can't diagnose somebody under the age of 18 with BPD. And Dr. Gunderson sort of said about adolescence, and some of the behaviors look like adolescence. But the real issue is that if we don't diagnose people under 18, then it's less likely for them to get better sooner. So we started an initiative called GAP, the Global Alliance for Early Prevention and Intervention. And the goal is to do conferences all over. We have some in the United States. We're going to Russia. We're going to Cuba. We're going all over to try to spread the word that this is a diagnosis that we need to identify early on so that people get the treatment that they need. The last thing I just want to introduce, and as I introduce my friend and colleague Marie-Paul de Valdivia, we also found that family members are drowning in the disorder because it's very hard to have a relative call you in the middle of the night and say that they're about to take an overdose. And just the way we believe that clinicians need intensive training and training to help treat our patients, we know family members also need to develop skills. So along with Dr. Alan Frazzetti, who's now working with Dr. Gunderson up at Harvard, he and I designed a program called Family Connections. It's 12 weeks. It's free. It's taught by trained family members. So family members come in and get trained to do this course. And we're so thrilled to say that Fountain House now is opening their doors so that we can have one of our Family Connections courses held on the grounds of Fountain House. Try to find free space in New York City. It's not easy. So we're eternally grateful to Fountain House, both not only for highlighting the disorder with all of you, but also now that we will have a home for Family Connections, a program that's in 20 countries, and the demand that we cannot keep up with. So thank you.
Hi, everyone. Can I ask you to call to mind a person who is most dear to you, someone you care about deeply? Perhaps it's a child, perhaps a life companion, or a parent, or a very dear friend. Yeah? Imagine now that this person is going through a completely chaotic time, and they're not doing a very good job of it. They're actually acting in pretty destructive ways. And you're there, and you know what to do. And as you try to help, you realize that they are behind a one-way mirror. They can't see you. They can't hear you. You're there, and you can do nothing. I'd like for you to join me in this story. It was on August 3rd, 1991, that I returned to Romania for the second time that year. I had been earlier to adopt a little boy, and this time I was going to finalize the adoption of a 2.5-year-old little girl who had had to survive by her own wits after the death of her birth mother 6 months prior to that. It was love at first sight. From the moment we met, she wouldn't leave my side and just fell apart in tantrums if I just went away. She was tough to raise, and she did exhibit some behaviors that were a little concerning, a little unusual, and educationally there were some discrepancies as she grew up. So she was in therapy, and we had her tested. And I knew something was not quite right, and so I asked everyone I could, teachers, therapists, but no one could really give me any guidance. No one certainly gave me any diagnosis. Nobody sort of knew what to do, or even what to watch for. By the time she was in high school, she had accomplished some pretty impressive achievements. She had raised a lot of money for various causes. She had been accepted to all the colleges that she had applied to, some of which were pretty impressive. And that is also the summer that she ran away from home. It turns out that she had been using substances for a couple of years. It also turns out that she had been self-harming for a while, and I had noticed nothing. And I'm a pretty hands-on mom. From there followed 2 years of complete chaos. This was my one-way mirror. It looked a lot like teenage, and it was definitely not teenage. One time she tried to jump out of the car on the highway. Another time she came home and she was under the influence, so it didn't go too well. And she was in t-shirt and flip-flops, and it was winter, and the temperatures outside were plunging. And so she left, and we couldn't locate her. We called the police because she was definitely inebriated, and we spent the night wondering whether she'd make it to the next morning. Our daughter went to rehab for one substance and then another. We didn't think things could get worse, and then they did. She turned 18. Nobody would talk to us anymore. The one-way mirror became opaque. As we were strongly being advised to send her to yet another rehab for alcohol this time, I had an intuition that what we were doing for this child was wrong, that she needed something else. And I continued to search frantically, and this is how I got to the McLean website. And on that website was the list of all the symptoms of borderline personality disorder, and there I was, all 9 of them. It was like somebody had turned on a light. Suddenly, everything made sense to me. I started to see sort of like the shape of a window in my one-way mirror. It was an incredible moment. 2 years of suffering for us, 15 years of misery for her. She fought me going there, but once she got there and she met the team, I will forever remember her little voice when she came to me and she said, "Mom, I can get better here. Can I stay?" So she did. She studied DBT. She studied it hard. And 4 weeks later, when we left, she did something that she hadn't done in 2 years. She came home. On our way out, the team told us that there was a conference on borderline that day at Yale. I had a lot of catching up to do and a lot of learning to do, so we decided to stop there on our way home, and this is where my journey started. When I got to Yale, I met this wonderful person, Perry Hoffman, who seemed to know everything about me and my child, even though we'd never met. She told me of Family Connections, this class that was free and that would last 12 weeks, and that was taught by other parents. She told me it was taught either in person or by phone, and my husband commuted at the time, and I really wanted him to take the class, so took it by phone. In that class, I found other people who were living the exact same nightmare. I learned about the illness, the facts about the illness, and most importantly, I learned to practice curiosity and non-judgment. I learned to understand my daughter's emotions and mine in response to hers, and to communicate those effectively. And then I learned acceptance on the one hand, and how to notice my limits and hold them and enforce them effectively on the other hand, that dialectic, right? This class is how my window in my one-way mirror just flew open. It changed my life in the most profound of ways. I trained to become a class leader, and then I heard about the wait list for this class, which at the time was 800 families. And so I joined the board of NEABPD to help grow our reach nationally and internationally. And at the same time, encouraged by mentors in this new community, I went back to school. And I started working with patients, but in the back of my mind, what I really wanted to do was work with patients with an eye to include families in the treatment. Because you see, all the families I meet complained of being kept at a distance from treatment. And it is so clear that most people who struggle with this disorder, or as I like to call it, this other order, do so much better when their families are involved. And most families really want nothing more than being involved, except in the face of all those huge emotions, they just don't know what to do. So to me, making this one of the foci of treatments made perfect sense. So with the support of wonderful teachers, I have continued to expand my work, working with patients and with families and bringing them together. So last year, as Consuelo said, I was asked to help direct the DBT program at Yale Intensive Day Hospital and also to join the faculty of Yale University, which is great because now I get to influence the next generation of treaters. I get to teach them and to teach them how to get involved in the art of treatment and also how to include families in the treatment. Most importantly, I'm in my daughter's life today, and she is in mine, and we have lovely times together. Her reality is that she struggles. Her life is hard. Addiction is hard. I would never have left my corporate career had it not been for this harrowing family experience, and it turns out I was made for this work. I love to do this work. So my child, in the end, has blessed my life in so many ways. I really, truly love what I do, and at the same time, I would totally give it up in a second if it meant that she could not suffer quite as much as she does. So this is my message, that perhaps she could have been better had this illness been detected sooner, had treatment been available back when I was so desperately searching for answers. Which is why what we do, to help families, to encourage detection and early prevention and appropriate treatment, and why we are here today. And I thank you.
So let me, I'm going to ask all of you some questions, and they gave me permission to, I think they're such esteemed professionals that I want to call them doctor and professor, and they gave me permission to call them by their first names, and said they prefer that. So John, let me ask you, we've been talking about how important early diagnosis is. Who is at risk? Is there a way of, let's say the symptoms don't manifest themselves, what are the risk factors that we should be aware of, that we could understand in looking at a child or a friend to head this off at the pass so that we can help them recover sooner?
I can only give a very unsatisfactory answer, and Perry, you may be able to add to this. First of all, it was surprising to learn that a lot of the people who developed this disorder are actually actively and repeatedly doing self-destructive behaviors in early adolescence. I always thought they started cutting when they appeared in the emergency rooms. But no, it's a private act originally, and so that's definitely a warning sign. Before that, though, in early childhood, these would be children who had insecure attachments, which might be manifest by being too preoccupied with a parent and their presence, too extreme reactions to separations. In addition to that, childhood trauma is a risk factor. Sexual abuse is the most specific form of childhood trauma. But in thinking about that, you have to understand that the person with the genetic makeup to develop this disorder is going to be more sensitive to the same environmental insult that another child with more resilience might endure without residual effects. So that's a handful of things that you'd look for. Emotionality and hypersensitivity, I mentioned earlier, are sort of more broad things, but that doesn't mean somebody's going to develop borderline personality disorder. It just means that if they are likely to develop borderline personality disorder, they're likely to have those characteristics.
And let me just ask you about genetics. So what
Yes.
is it about genetics? And again,
There are
what can we do?
two major theories as to what is inherited, but neither of them are confirmed, except that the interpersonal sensitivity, so that you may have a child who is particularly sensitive to, let's say, a separation or a frown, that may be genetically loaded as opposed to something that is caused through early caretaking. Also, excessive emotionality. That also may be the marker of the genetics of the disorder. They are quite different. They may coincide, but we don't know yet, and that's a great area, a great challenge.
Perry.
I wanted to add the idea of what emotion and sensitivity means. And what it means is there's sort of three steps to it. One is the immediate reaction. The reaction to something is more immediate. It's more intense, so it goes to a higher level, and it takes longer for the person to get back to a baseline. So if you almost think you're driving in the car and you've almost had a fender bender, that the rest of that car ride, you're sort of up here. It takes you, maybe the next car ride to feel more comfortable. But that's what it's like to be emotionally vulnerable. I also just want to say a minute about the family members, because they have been vilified, originally thought to be the cause and all of that. And it's hard, and Marie Paul did a beautiful job of sharing with you what it's like to have a child with emotional needs like that. But what it also creates is a very difficult transactional process. And there's a setup, Marshall Linehan calls it the invalidating environment. I like to call it the incompatible environment, because somehow invalidating to me is invalidating. But incompatible to me means that it's just not a good fit. And a mother can have 3 kids, and with 2 children, it just goes well. But that third child, because of the emotional sensitivity, it's just harder to be a parent to that child. And that's sort of how we understand that we can see some of this in childhood. And then, of course, there are specific incidences with children. And as John said, cutting sometimes is thought to be a fad. And then if it goes on, we know that it's much more serious than that. Also, up to 33% of adolescents who get hospitalized have borderline personality disorder. So we're seeing it. We're just not willing to say it. And that's the message we need to get out there. It exists at much younger ages than 18.
Male, female, any differences?
I wrote the textbooks.
Yes, you did.
Wrong. But for years I thought it was predominantly a female disorder, because that's what we saw in clinical studies, about 80%. But when you did good epidemiological studies, it's 50-50. It's the males who are less apt to appear in mental health settings and more apt to appear in substance abuse or forensic settings. New York City's great football player, Brandon Marshall, was the first publicly recognized person to go public about this disorder. And I don't say it's because of that alone, but I know that we now see a lot more males in our borderline personality clinical services than we did a few years ago.
You asked a little bit about what could be done with early detection.
Yes.
And so in my experience working with like hundreds of families, particularly through Family Connections, a very common theme is parents saying, if only we had known sooner. So parents talk a lot about children who were difficult to raise. They didn't quite know why. There was extreme sensitivity, as you mentioned. And they didn't know. But learning about the skills that we teach in Family Connections often leaves families thinking, if only I'd had those skills sooner. And that speaks a lot to the importance of early detection as well, to be able to get in sooner and shape that life path a little bit differently.
And can you give us, what are the skills? And I'm sure that the skills are what good parenting would entail anyhow, plus, right? Is that the case, or is it a really different skill set, and therefore, we need to go through
I would say that you add, actually, yes, good parent. What do we all want for our kids? We want them to grow up and be happy and be somewhat functioning members of society, and that's a good thing. With children who are particularly emotionally sensitive, as Perry just described, a little bit of a different approach is necessary. We parents tend to be, it's the job of parenting, and I think that's something you said, right? By nature, parenting is invalidating. We tell kids to behave a certain way. We tell them that it's not okay to steal, and that's a good thing. We should tell our kids that it's not okay to steal. But a child who is particularly emotionally sensitive will get crushed by that statement. And so learning some of the skills, some of the specific skills, such as how to validate, how to notice emotions, how to speak to an emotion, will help us respond and absolutely not let our child steal, but do it in a way that is more aligned with the child's needs. So a lot of the skills that we teach in Family Connections are based on DBT skills. They're not all, but they're based on DBT skills, and they do circle around this ability to be curious, to be non-judgmental, and to validate, to show that we understand them and why they behave in the way that they do.
John, you want to add?
This was a difficult concept for me to wrap my head around, but once I got it clear in my own mind that this is a serious psychiatric disorder with a significant genetic base, I began to see more the need to customize the home environment. That is, this is like a handicapped child. And the children with the disorder do not welcome that news because they are accustomed to thinking that their problems are caused by the outside world. But it is an adaptive adjustment for them to make, to think of themselves as having handicaps, which both they and their family need to learn how to accommodate and make adjustments that they wouldn't naturally make. And one of the most simple examples is kids having trouble, and the parent says, "You can do it." Well, in general, that's a good thing to say. But if your child has borderline personality disorder, what they're going to hear is they think that this is a personal failure of mine. They're saying, I should have done this, that I'm responsible for my failure. So you're giving a message unwittingly that is actually harmful.
The audience responded that a number of you have had experiences, or family members, friends have had experiences. So let's say they're adults and they have borderline personality disorder. What do you do with an adult? I mean, is there hope? This prognosis of hope, is there hope for an adult? Where do they seek treatment?
Excuse me, but the research which was done that Perry talked about, there are 2 longitudinal studies one sample with hospitalized patients at McLean, they're selected. The other study was from 19 treatment centers in the Northeast, representative of the general population demographically and ethnically. They're all adults, and the course that we described is for adult patients. Now, if you started with 15-year-olds, you'd have a better prognostic group. So the longer this disorder is sustained without remission, the prognosis gets less.
You know, all of you mentioned as well that there frequently are other issues. I know with your daughter, it's addiction. And but to talk about, you know, the other diagnoses, and is it ever a standalone disorder, or you know, does it frequently, and again, the complexity of how it's frequently misdiagnosed. So Perry, would you address that?
Yes, actually, I'll say personally that I've never seen someone with borderline personality disorder without another diagnosis. And we often say that it rarely stands alone. Now, someone else, a clinician, might say, no, they have, and I believe that, but it's unusual to find somebody just with the disorder. About 60 to 70% of people have major depressive disorder. 15% have bipolar disorder. About 25%, I think, have substance abuse or an eating disorder. And this certainly complicates treatment, and you have to treat both. The important piece to remember is if somebody has borderline personality disorder and, let's say, major depression, the major depression is not going to lift until the borderline symptoms are under control. So oftentimes people will go and be diagnosed with major depression. The borderline piece is never picked up, and so the depression never gets identified. What I find very unfortunate is those of us who are BPD clinicians, we're always looking for co-occurring disorders, but I don't think the other diagnoses are looking for borderline personality disorder. So they're not sure, and I've gone to like ADHD, which some people believe is a precursor because the environment just doesn't know how to meet the needs of that child, might be a precursor to borderline, but never in an ADHD conference have I heard the word borderline personality disorder. So that's an unfortunate piece here because it's not being recognized. And if it's not being recognized, it can't be treated.
And how enlightened do you all feel that your peers are in therapy or psychiatric care as MDs, as PhDs, as social workers? What's the penetration of enlightenment about this disorder?
I think most modern psychiatrists are very aware of the diagnosis. That doesn't mean they're very consistent in being comfortable diagnosing it, and many of them actively avoid treating these people. We are engaged, as Perry said, in introducing a treatment model which is for a generalist model that all mental health professionals should have, what every professional should know. The other side of that is that every borderline person with borderline personality disorder, she has a right to expect that the professionals who treat them have had training. That is, I think, a straightforward mandate which is only gradually getting fleshed out. Having a simpler model so that the psychiatrists can't siphon this off and say, well, that's borderline, that requires a specialist with very intensive, extensive training, which are never going to fulfill the public health needs, really should be in a position of saying, what I can't know is good enough for the majority of these patients. That's true for psychologists and social workers too. And then, if they don't get better with a more basic training package, then you kick them upstairs to the specialists with DBT training or MBT or TFP or other acronyms to be developed.
Would you agree with that, Perry, with his assessment of the knowledge among the professionals?
Yes. What
PhDs.
John and I do is at the American Psychiatric Association conference each year for the last decade, I think we've been doing a workshop for residents because we believe we need to get in early with doctors in training and teach them about the disorder in a way the way it is today and not the way it was before. I know in social work schools, they're talking about the disorder. What they're actually doing is training people or giving a course on DBT, which I think is interesting, that they're really trying to orient young professionals that this is a disorder that's treatable. But we do have a long way to go because there's still some old-fashioned thinking, and that's a hard thing to get off the board.
And Fountain House is about hope and about recovery. And you, Perry, you mentioned, that the good prognosis diagnosis. And so if each of you could address what you are most hopeful about with BPD, what are you most hopeful about, Marie Paul?
At Yale in the intensive psychiatric outpatient day program, we treat pretty acute individuals. We treat adults mostly who are in their mid-30s all the way up to their 60s. And we just looked at the recurrence rate, people who come back for treatment, and we're just barely at 10%. And so to me,
Only 10%
only 10%
have come
of
back
people
for treatment?
come back for treatment. And so that doesn't mean, we don't have data that talks about how people who don't come back are doing. And I don't want to give an impression that, but the reality is that there is a great deal of hope that we see over our period length is 4 months. Over the 4 months, we really see people getting better as they practice the skills that we teach them and as they engage in this sort of, and that's what I saw with my daughter, really, this sense of hope. You were stuck, and now there's a way to get past that stuckedness.
So if they continue to behave the way you were training them to behave, the recovery can be lifelong?
If they continue to use the skills and practice the skills and make the skills sort of second nature, and if they re-engage in the workforce, if they create a structure for themselves, and for sure this is really hard. I mean, we're asking them to work very, very hard, but it is feasible, it is possible, and to me, that's where the hope lies.
Perry, how hopeful are you?
I'm hopeful because we've built such more of an awareness on this disorder. I mean, the fact that Fountain House is doing this luncheon on borderline personality disorder, to me that says it all. I mean, it's not the population that are serviced in the facility, but the interest in the disorder is really growing and growing, and that gives me hope, especially since we have these treatments, because now we can offer something, whereas maybe 25 years ago we couldn't. And then when I meet with families, and it's really an honor to meet with a family and present to them the latest on the disorder, and their life turns around just hearing. I had a patient who came to me the other day who said, I was told it'll take 5 years to get me better, and maybe I won't get better. And I said, not true. Not true. And the fact that you have something to offer people and people get better, hope builds on hope, and that's a wonderful journey to be on with so many people.
I guess my comment is a variation on that. I think that the most hopeful thing to me is that attitudes will change. It takes about 15 years lag between a scientific discovery and its actual integration into the education system. And we're at a point now when I think that the information about the genetics of this disorder, the expected course, and the fact that well-informed clinicians with their feet on the ground can help most of these people are all discoveries within the last 15 years. And I think and single days like this, single meetings like this can change attitudes. And so much of the problem that borderline patients have faced is related to the attitudes of the people that they confront in treatment settings. We've all been very misguided and misinformed. I think that's changing.
That sounded like a wrap-up question. It was close to being one. However, let me ask you all one more, and maybe you've done it in answering that question. But if there's one thought that you would like to leave us with about borderline personality disorder, what would it be? Who wants to go first?
I'd say that these people are very lovable. They don't lead with the best presentation, but if you get involved, they can be very rewarding to work with.
I want to acknowledge that as well in the same way. It's really an honor to be working with the patient and also with their families. I also want to, because I didn't mention it before, we have an organization that Consuela mentioned, but we have a website that has the largest media library in the world on borderline personality disorder. So please go there, and we have hundreds of videos that date back for over 10 or 15 years. You can actually watch some of the sea change from the presenters. And the name of the website's very easy to remember. It's borderlinepersonalitydisorder.com. And
Thank you for making it so straightforward. Marie-Paul, what would you like to leave us with?
I would, if I have a wish, it is that we not characterize people as borderline. There is no such thing as a borderline. There is somebody who struggles with symptoms, with difficulties, some of which are evidenced as borderline symptoms. And when you work with people who struggle with borderline, you notice how different they are from one another. But what most of them have in common, and I think that is why they are so dear to my heart as to yours, what they all have in common is incredible courage. It takes courage to fight this illness, and those who do are warmly rewarded. Most families are there. We're talking about skills. You know, they need to learn skills, families need to learn skills, and magic happens. Magic happens.
I think it takes tremendous courage to do the work that you three are doing. And thank you so much for taking on such initially in your groundbreaking work, such a difficult disorder that no one wanted to treat. And in doing the research you've done, John Gunderson and Perry Hoffman, the work that you're doing, and Marie-Paul Devility, thank you so much as well. So we really appreciate your being here and discussing your life's work with us in such clear and concise terms. It is now time for lunch, lots of food for thought, and we'll resume the program in about a half an hour. So please, a round of applause for our panelists. Thank you. That was great. Really great. Wow. That was...
It gives me great pleasure to introduce today's honoree, my friend Amanda Wang. After receiving her diagnosis of borderline personality disorder in 2007, Amanda founded the first in-person peer-led support group for people living with borderline personality disorder. She has gone on to author a blog, host a podcast, and to speak publicly about her own story and the hope within the borderline personality disorder community. I would now like to welcome to the podium this year's Fountain House Humanitarian Award recipient, Amanda Wang. This is an original work of art from a member of Fountain Gallery, and I would like to give this to you, Amanda, in thanks for sharing your story and being an inspiration to so many people living with borderline personality disorder. I'm really proud to present you with the 2017 Fountain House Humanitarian Award. Keep up the good work, Amanda.
It is with a grateful heart that I share this award with you. Now, I know I may not be an actor, a professional athlete, or a physician, all likely recipients of such honor. Perhaps I'm here today because I might remind you of someone you may know. As a girl born in Queens, deeply rooted in family, I grew up with an intense sense of creativity and all the while still very unhappy. At age 15, everything I once thought to be true collapsed in on itself, and by 19, I dropped out of college. And then at 28, again at 34, and this most recently, this past winter at 38 years of age, I have found myself crying on the inpatient floor of a New York City hospital. I have been on the brink of thousands of deaths, created nooses out of belts more times than I can count on my fingers, and looked to subway tracks for salvation each time they whizzed by. Day in and day out, I'd question my very existence, and yet somehow, some way, some reason, I am still here, standing before you. It is perhaps because each time, each moment, when the struggle seems too great to endure, I have asked something from you, my family member, my friend, my mentor, or my teacher. I have asked of you a promise. And I'd say in some form or another now, I'm going to do all that I can to live out my life if you just please believe in me. Those are the words that have brought me to my knees and picked me up on my feet. For when I've been on the brink of death, when I've been determined to die, and having held that noose in my hands or stood upon that very ledge, I remember the promise I made. And so I'd phone you, and you dropped everything to see me with all my pain and confusion, with all my shame and self-loathing, with all my despair and longing. And still you say, Amanda, I see you, and yes, I still believe in you. In those few moments when the pain of 1 minute seems to last an eternity, whether you are my friend, my husband, my high school teacher, or my therapist, you have shown a spotlight unto my wounds and recognized me for all that I am. Because you lingered there and told me there was nothing to be ashamed of, that it was okay to be who I was, to be human, to be me, I began to believe that this struggle no longer prevented me from living, but in fact can be the very reason why I am alive. For now, my struggle becomes an opportunity for compassion, and my pain a battle cry to continue on. My curiosity a reason to remain curious. Excuse me. You see, you have helped me become my own kind of hope. Now, I know I have borderline personality disorder, but I also know that this pain will never fully go away. I don't know if my pain will ever fully go away, but we of the living cannot wait until then. There is too much to do in the time that we have here to wait for it to go away in order for our lives to begin, in order for us to do the work we are called to do, to be all that we are so that others can be all that they are too. So today, right now, right here, in a sea of hundreds of people, I ask that you make a promise to those who struggle. Believe we are worthy of striving, worthy of pursuing, worthy of our wounds, and worthy of our lives. For when we share our wounds with one another, when we see eye to eye, when we believe in all that we are, we realize not only how much we can do, but how much we matter as we share our humanity and our hearts for each other. Now, in light of the promise that I asked of you, I invite you right now to turn to your neighbor and say, and I know this might be a little awkward at first, but I ask you to be brave and look at them in the eye on the count of 3 and say, I see you. You ready? 1, 2, 3. I see you. Now we are ready to believe in each other, and I believe in you too. Thank you very much.
Wow. Thank you so much, Amanda. That was a really important message for all of us. Your courage and advocacy in speaking openly and honestly about your experience with borderline personality disorder is an inspiration to all of us. I was told that there are 582 of us in this room today, which is a great, great thing. And we all want to express our gratitude to everyone here today for joining us at this 14th annual Fountain House Symposium and Luncheon. Because of your support and generosity, I'm pleased to tell you that today's event raised over $1 million for Fountain House. So, we really look forward to seeing all of you again next year on Monday, April 30th, 2018. Save the date. Enjoy the rest of your afternoon.